A couple of announcements before our next speaker. For those of you who have questions after the speaker, please wait for the microphone because they are recording the talks and the question and answers for placement on our website. After lunch, Dr. Greyboys will be outside at the desk signing his book for anyone who's interested. And in terms of the parking, you only have to pay once to get in. So if you have that little sticker that you put in your windshield and you need to go out, you can come back again today without paying again. And our lunchtime speaker is Dr. Norman Foster. And this is in keeping with the theme of the last two speakers. He is a professor of neurology and the director of the Center for Alzheimer's Care at the University of Utah. And he'll be speaking on the proactive dementia care beyond standard treatment to prevent crises. Dr. Foster.
Thank you very much. I really appreciate being asked to come and speak, and I have been extremely impressed, as I've mentioned a number of times, about the large turnout today and how it must be difficult to get any other medical care in Ogden these days. It's such a great turnout, and it's really something to be proud of because in academic centers throughout the United States, it's becoming more and more difficult to have conferences like this one that cover a broad range of topics. Everybody gets so super specialized that it's really a problem. My talk today is going to be following along the theme of the changing face of American medicine. And I'm going to be talking about a new paradigm for caring for people who have dementing diseases. And I've been set up by this. Dr. Greyboys and his wife have eloquently described some of the challenges that patients find and physicians have in providing care for patients with neurologic disease that's chronic and often progressive. And then Moni let me bypass a lot of the details and the exciting science that we now have to apply to these diseases. And so we really need to be able to take advantage of what we're learning about Alzheimer's disease and related disorders to make a difference for our patients. Many of you may have heard data that show that in Utah we have the greatest challenge of any state in the country. In fact, in the next 20 years, the number of people with Alzheimer's disease is going to be increasing more here in Utah and more in the Intermountain West than any other region in the United States, with projections of increasing more than 150% over the next 20 years. And unfortunately, we're not prepared to meet that challenge very well. So we need to make some changes. And I'm not sure whether healthcare reform is going to help or hurt those changes. I hope they will help, but certainly we need to be looking for new answers. It's an important consideration that here in Utah, many people are not diagnosed with the cause of their dementing illness, and that fewer than 3% of people with Alzheimer's disease in the state of Utah are contributing to advancing knowledge for better diagnosis and treatment. So these are important challenges. Now, I really appreciated earlier talks this morning, and one of the themes that came out is that early treatment is better than delayed treatment. And this is particularly true in Alzheimer's disease. So how can we make progress? As you can see, I have many potential conflicts of interest, but I don't think that any of them are related to the discussions that I will be leading here today, except for the fact that the University of Utah has been the recipient of a significant private gift from an anonymous donor that helped establish our center in 2005. It allowed me to come here for us to recruit colleagues and We now have an excellent program focusing on imaging. Some of the work that Moni talked about, for example, we're one of 3 centers in the United States that is funded by Medicare to do FDG PET scans in people who have mild cognitive impairment and not dementia, to see if what he was showing actually has significant impact in care for patients. So what is standard care for dementia today? Well, in the Intermountain West, primary care physicians provide the vast majority of care for patients with dementia. And they do this unassisted. And that's really a tremendous challenge that I am very sensitive to, because this is one of the most serious diagnoses that can be made. As you heard, it can impact patients and their families. And as far as I can tell, it's the most serious disease that primary care physicians are expected to diagnose unassisted. If somebody has a mass in their lungs, usually they have a radiographic study that demonstrated that. Patients are often referred to have a biopsy. Primary care physicians don't have to decide without pathology results or the advice of a specialist that you have lung cancer, a similarly serious disease. So it's really a challenge. And because of many factors that you know better than I, what we end up having is often what I call default care, doing what's required at that time in the short visit that is available. And often there's an expedient for a single patient encounter. When we receive calls from family members about a problem, often we prescribe a medication, adjust a medication, put a Band-Aid on something without getting to the underlying problems. And too often, diagnosis is by intuition. Well, it seems like Alzheimer's. Often patients come to us saying, we haven't been told what this is, except maybe it's dementia of some type. Now, one of the responses to default dementia care is what I call reactive recognition. In other words, we do a pretty good job if a patient or a family member comes in and complains about a memory problem or decline in of abilities in patient's performance. However, even at that point, the response of the physician or mid-level provider can make a huge difference. In one family that came to me, diagnosis was delayed about 4 years because the physician's initial response was, "You're the problem. Why are you complaining? The patient seems to be okay to me. Get off his case. This is not a medical problem. You get help for yourself." And that took her back so much that it was only 4 years when she was able to get the courage to come back and really make sure that it wasn't her problem, that it was the patient's problem. Now, treatment, we're kind of inhibiting ourselves, a little bit like trying treatment with one arm or both arms behind our back when we don't know what the cause of the problem is. If there hasn't been a diagnosis, we don't really know what we're treating. As a result, care is inconsistent, and we don't really have a good plan long-term for management. And often, actually, as I show here in a reference, primary care physicians say they're giving drugs simply to try to do something, not really sure what they are doing. So it's clear and it's quite understandable how this kind of default care occurs. This is not a topic that's discussed very much, even in medical schools today, even despite the high prevalence of these diseases. Fortunately, we've made some progress at the University of Utah, and medical students get 3 hours of discussion, neuropathology, pathophysiology, and clinical diagnosis and management of Alzheimer's disease, but many of us who went to school years before didn't even have 3 hours of training, and many people go through training without this. Of course, everybody has their interests, inclinations, and so this may not be a topic that's important to everyone, and that's natural, and I think that's appropriate. But if you are expected to also give care for patients with Alzheimer's disease in your daily practice, that's hard and may be a problem. And I also recognize that the healthcare system does not help us out in this at all. I'm looking forward to the discussions this afternoon about this, because you have to have an adequate amount of time, and many practice environments are not conducive to adequate care. They fail often. We often are unable to provide additional time. Now, it's very interesting that some recent research really has been done to look at how care is provided in the United States now. And this is an interesting paper from Journal of American Geriatric Society, where researchers actually went into offices to see what happens in this physician and patient interaction. As you can see, this is a fairly large number of visits, a reasonable collection of doctors. And what happened is that they videotaped this interaction, and then they, in the part I'm reporting is just that they measured how long the interaction was regarding mental health problems. I don't think this is much different from how we interact in patients who have dementing diseases. And they then ask, after the visit, patients about their mental symptoms or psychiatric symptoms. They found 50% of the patients, elderly patients in this group that they had videotaped, had symptoms of depression. And yet this was picked up only in 22% of those physician-patient interactions. What was shocking to me, it may be expected for you, I don't know, I'll be interested in comments later, but the median amount of time spent in those interactions when depression was addressed was 2 minutes, which accounted both for what the physician had to say as well as what the patient said. This isn't a problem of physicians. We can't put that all on physicians. I think this is a lot the system that doesn't reward or expect this, and it puts us in a negative start even to these kinds of problems. Well, there's a lot of evidence that this kind of default care for dementia doesn't work. There's good evidence in published literature that diagnosis of dementing diseases is delayed, that physicians often don't have confidence in their diagnosis, and as a result, treatments are often inconsistent, aren't given consistently, that many patients receive inappropriate treatment. I'm often asked about the costs of dementia care, and in fact, Moni last night raised this question with me: how can you justify the costs of dementia care? And I would say that the costs are actually already there. We're just not using this very efficiently. That patients come to me often with duplicated studies. I had a patient recently, it was kind of interesting, had been seen by the physician 15 times, had 5 CT scans, and never had a diagnosis. The doctor had never decided what the cause of the problem was. There are often uncoordinated care too, and this leads to poor quality of life, not only for patients but also their families. What is really expensive in dementia care is institutional care. It's crisis care. It's trips to the emergency room, unnecessary hospitalizations, and in fact there's a lot of evidence as well that all kinds of medical costs, including hospital costs, medication costs, are greater in people with dementing diseases than their non-demented patients of similar age. So there's something we can do about this, and I want to suggest some ways in which we can do a better job. Now, one of the ways that you might think we could do this is, if it's not appropriate in primary care practice to focus on dementing disease, how about just referring to a specialist? But we have a particular problem here in Utah. There are very few specialists that deal with this problem. In fact, our center is the only one that focuses solely on the care of patients with dementia in the Intermountain West. And we can't do this by ourselves. There are a number of neurologists and psychiatrists, of course, here, but those who focus on the elderly are quite small. In fact, there is only a single geriatric psychiatrist in the state of Utah, and he practices at the VA and doesn't see patients. There are very few geriatricians. In fact, in the state of Utah, there are fewer geriatricians, board-certified geriatricians, than almost every state other than states like Wyoming, Montana, Idaho, that are also in our catchment area. Now, it is true that patients who are seen by specialists are more likely to have a detailed history and more time is devoted to their care. But even in this setting, specialists unassisted or not focused on the kinds of care that I'm going to be talking about rarely link families to community resources and may not, without a team to help them, be able to do all that's necessary for patient care. Now, the traditional approach to dementia care clearly needs to improve. You may have heard about the phenomenon of granny dumping, where families were unable to get adequate assistance or guidance, and in frustration, often on Friday afternoons, would end up in an emergency room and be bye-bye, we're off to the campsite or off on a vacation. Fortunately, this is happening less. And since I arrived here in 2005, the number of Friday afternoon calls I've gotten from my patients anyway has almost gone to zero, fortunately. But this is still a problem. And the response initially was, this is a problem of families. Why aren't they taking care of their elderly? Well, we did not give them the tools that they needed. They didn't know what to expect. They didn't know where to turn. We didn't help them find where to turn and to learn about their disease. It's possible instead to help them prepare. Our thinking about dementing disease has changed significantly. Everyone with a dementing disease is receiving long-term care. They may not be institutionalized, but they're receiving long-term care, just as you've heard earlier this morning. And they need increasing assistance, but the most effective, cheap care, or the most effective care, turns out to be the cheapest care. And many patients' families are able to provide one-on-one or even several-on-one care at home, where institutional care usually leads to one provider for many different patients. So you can see even in this straightforward way that institutional care isn't as ideal. However, this is not something that people come to naturally. Just because I raise children doesn't mean that I know how to deal with somebody who has a progressive dementia. These are different skills that have to be learned. Another thing that we have learned in our research is that it makes a difference what happens to patients. One of the early studies in Alzheimer's disease was done in New York at Bronx VA, and they looked at the rates of progression of dementia. The people they tested were veterans in an inpatient unit who sat down in the day room most of the day in a wheelchair with the TV on. And they showed a rapid progression of symptoms. Then when we began to do outpatient clinical trials for Alzheimer drugs, we predicted how many people would be needed in the study based upon those institutionalized cases, and people weren't progressing nearly as rapidly as we expected. People at home who were interacting progressed at a less rapid rate. That's one of, even in placebo studies, people seem to be getting better. There's lots of other supportive evidence, but it's important for patients not to be isolated, that they be mentally active as possible, physically active, and be socialized. And this is also a way to improve quality of life. So, what does 21st century dementia care look like? What should it look like? Well, we ought to be looking for mild problems and figuring out when they're significant and when they aren't. We need to be using data-driven diagnosis to make highly accurate and specific understanding of the cause of the disease so we can prescribe treatments that are appropriate for the disease. We need to intervene early, like with every other medical illness. We need to assess risk for preventing complications and crises. We need to guide families to make necessary life adjustments. These diseases require major changes in expectations, in the living situation. Driving we've heard about, but in other ways as well. We need to empower caregivers by educating them so that they become effective partners rather than calling on the doctor in these unreimbursed calls to the office, not knowing how to handle a particular problem. They should be able to be given resources so that they can handle most of those cases. And as you heard earlier, attending support groups can make a huge difference. And we need to have coordinated care with all providers. We know that medical illnesses, comorbidities, can make a big difference in patient outcomes. They can also make a big difference in cognitive outcomes. The solution is not to take patients away from their primary care providers. Their medical needs also must be met. We need to have better collaborative care instead. So we need to have proactive recognition. Patients may be having a dementing illness but may not recognize it themselves, or as we heard earlier today, they may be reluctant to recognize these problems. Even family members may be reluctant to identify a problem because that may mean a big change for them. They may have to provide the transportation for their husband. They may have to not consider retiring to this rural getaway or moving to Hawaii. They may need to be around family members. And so we have to be looking for these problems ourselves in our interactions if patients can't follow directions during an exam. Even things like relying upon others for transportation when that hadn't been true in the past. And a very important one in everyday practice, someone who has been managing their medications well for many years, then all of a sudden they're not doing it so much. Their diabetes is going out of control. The Coumadin seems to be out of whack more often than before. Even missing appointments can be a warning sign that there's dementia. So what is the role of primary care physicians? Well, this early recognition is one thing. But we recognize that, I don't know, how many people here have a memory complaint? I mean, I do. I don't remember my patients' names either. And I hope I remember some of you who I get to meet. But all of us have imperfect memory. So memory complaints are common. They do not always represent a cognitive deficit. So we need to assess a person's memory if they have a memory complaint and try to decide whether that's significant. And there are several ways, as you can see here, to do that. If someone does have a significant cognitive deficit, then we have to think about the possible causes. And primary care physicians are in an excellent position to make some of these early judgments. Are there medications that are causing it? In the past couple of weeks, I have discontinued Ambien in about 3 patients, benzodiazepines in 1 patient, and unfortunately, narcotics are a major problem in several of my patients. So the medications are the most common reversible cause of dementia in the community. There are cases in which sensory deficits, macular degeneration, can be confused with a dementing disease. And depression is often both a complication and a complication of dementing disease, such as Alzheimer's disease, but also can cause a memory problem just from the depression alone that can be reversible. I think that it is appropriate if you feel that you have not been adequately prepared to make a specific diagnosis and work with family for a long-term management plan and engage them in supportive care as part of the care team to refer to a multidisciplinary team to address these problems. Now, I don't have time to review all of the issues about dementing diseases. Here are a couple of books that I contributed chapters to recently, and the important thing is the number of pages. So it used to be, when Moni and I started out, there was maybe a little 10-page summary about what we know about dementing diseases, but there is a huge amount, not just on Alzheimer's disease, dementia with Lewy bodies, different flavors of frontal temporal dementia, and vascular dementia, many other dementing illnesses. So there's a lot to consider in differential diagnosis. Now, here are the most common causes of dementia, and I'm not going to review them. The most common is Alzheimer's disease, but the point that I'm making here, along with dementia with Lewy bodies, Parkinson's disease with dementia, frontal temporal dementia, these are all neurodegenerative diseases, but there are also things like vascular dementia, which is a preventable dementing disease, and they have different characteristic clinical features. They have a different pathology, and you can imagine diseases with different features, different pathologies have different appropriate treatments, and they also have additional pathologies and complications. Again, I'm not going to go through all of this, but it's important that all dementias are not alike, and they don't need to be alike. I want to, for those of you who refer patients to us, I need to talk a little bit about Alzheimer's disease and Alzheimer's terminology. These are the criteria that those of us in the field use for Alzheimer's disease. Probable and possible are the most common clinical diagnoses because we have reserved for definite cases to those in which we have certainty about the diagnosis. We can have certainty in some cases because there's a brain biopsy, but that's vanishingly rare. We can be certain in some cases because of a known causative mutation, and we can be certain after death when pathologic confirmation, just like the patient who has that lung lesion and it looks like a tumor, could be lung cancer, but it might be TB or it might be something else, abscess, for example, and so we need to have more information. So right now, until Moni gets a little better with these biomarkers, we can be fully confident, we are honest with ourselves and restrict ourselves to probable in patients who have typical uncomplicated symptoms of Alzheimer's disease. Pathology shows we're this accurate. And when there's an atypical presentation or complication, for example, somebody who's been on renal dialysis for 10 years and develops a progressive dementia, that's not an uncomplicated case, that's a complicated case. The renal disease may be contributing. We're less certain. We recognize this with possible. I wanted to point this out because when I send you a note and say that somebody has Alzheimer's disease, probable AD, I don't mean they probably have AD or possibly they have AD, maybe they have AD. This is actually a specific and acceptable clinical diagnosis. Well, I was asked to talk a little bit about treatment, and there are standard treatments for Alzheimer's disease specifically that are listed here. In general, it's best to try to avoid psychoactive medications in people who have limited cognitive abilities, but you'll hear plenty about these standard medications. The point is that different dementing diseases need different kinds of therapy. Vascular dementia is treated in a different way because the goal is to try to prevent progression by preventing further vascular damage to the brain. And so there's a whole different group of tests, different drugs, different approaches that are appropriate. But we need to go beyond prescribing medications. What we're developing here at the Center for Alzheimer Care at the University of Utah is what we call proactive care, trying to identify problems early, give patients knowledge about the disease, how to seek reliable sources when we're not there to answer their questions. There's a lot of stuff on the internet. They need to have some guidance about what to look for and what not to pay attention to. And they need to get specific skills. And one of the best ways to do this is by having education, connecting patients with community resources like the Alzheimer's Association, giving reading material. But one of the things that we've developed is what we call an education prescription. This is every patient at every visit in our clinic sees our health educator based upon a physician-directed education plan. Just as important as a prescription for medication in this disease is a prescription for education, things that people need to know. I'll tell you a little bit about how I came about this. This was courtesy of the New York Times Sunday magazine. It was an interesting story where the reporter was going with his wife, preparing for their first child. And they decided this was really an important event. They wanted to plan, do the best thing for their child. And so they went around, I didn't do this myself, but they went around and interviewed a series of obstetricians to decide who would be the best for them. This is kind of a New York thing to do, I think, as opposed to just asking your friend who you went to see. So they went around and interviewed, and he told an interesting story. He said that he had met with a doctor. It was very pleasant in his office, and they were asking him questions. They were very positively disposed to this doctor, but they were interrupted by a telephone call from one of his patients. And it came out that the problem was, this is a patient who recently had delivered a baby, and she was calling to ask if she could be pregnant again. And yeah, it looks like you haven't had period, and all these changes you're noticing. And sure enough, she was pregnant unexpectedly, even though she had been breastfeeding. And the doctor hung up the phone and said, if I had a nickel for every patient like that who goes off and doesn't realize that they can get pregnant right after they've had another child, I'd be a millionaire. And the writer and his wife looked at each other, excused themselves, and said, that's something that was predictable. Why wasn't he warning his patients that kind of thing could happen? Doesn't always happen, but it was predictable, and that was preventable. But this doctor thought that his job ended after the delivery and didn't need to educate patients about those kinds of problems. So this is where we stand in dementia care. There are unexpected but predictable crises that can prevent. So I just want to go through several of these as we do this at the University of Utah. We assess risks, individual risks. You can think about how this might affect your family, or your patients. So here's someone. What is their risk of legal or financial complications? Do they have an advance directive or not? Do they know the financial implications for the disease or not? You may or may not know that Alzheimer's disease for family finances is the most expensive illness that you can have. It's much more expensive than liver transplantation. It's often, the costs of care for liver transplants are often covered by insurance. Nursing homes are not covered by insurance. Assisted living is not covered by insurance. Daycare is not covered by insurance. And many people many families are financially ruined by dementing diseases. So these are things that patients need to be able to plan for. And the tragedies that can be avoided with advanced health directives are significant. What about safety? Well, we talked about driving. That's an obvious thing. What if the person's driving against medical advice? We need to identify that. What if they're becoming lost or wandering? There's a strategy for that. We heard about a lifeline, which is one strategy. There are many others. The Safe Return Program through the Alzheimer's Association is a possibility. There's an interesting study that looked at sleep disturbance in Alzheimer's disease. And the part of the study that was very interesting, sleep disturbance is a common problem, but it was common in people who did not get regular physical activity. And the study actually found that at baseline, only 7% of patients with Alzheimer's disease who had sleep disturbance were getting out of the house daily for physical exercise. 7%. After the intervention, about 50% did, and with significant benefits for sleep. But this also makes a difference in fall rates, which are increased in Alzheimer's disease. And as you've heard, particularly in patients who have dementia with Lewy bodies, this makes a significant difference. What about mood? Well, mood is a big problem for caregivers. About 30% of caregivers have depression sometime in the course of the disease, but patients also can have difficulty with mood. And not having anything to do during the day is a big contributor to this. One of my colleagues said that the key feature of Alzheimer's disease is it's the most boring disease you can get. You're used to reading. Now you don't have anything to read. You're used to going and watching TV. Now you can't follow it. You're used to getting out with your friends, and they've gone away. Just think about it. The patients need to have things to do that are appropriate for them and their disabilities, that are mentally stimulating. They can be involved in recreational activities. We heard about a great one, dancing, and it can make a difference in attitudes, but also in functional decline. Patients should be encouraged to do as much for themselves as they can rather than being dependent upon others. We heard all of this this morning. And the risk of social isolation. You can see we have criteria here for what that means. And one of the things that we focus on is identifying early, before it's lost, the social support network that all of us have, before it's lost. It's very difficult to get people engaged in patients who have dementia, particularly if it's severe already. We think about this, we make an analogy with the basketball team. So we're going to play a game. We're going to have a coach, who could be the physician or the mid-level provider. We need to have a team captain, could be the spouse, but there needs to be a team that's going to play this game. And they need to know what the rules of the game are. If they don't know the rules, then they're not going to be very effective as a team, and they're not going to be able to win that game. You don't wait until the fourth quarter, when you're 30 or 40 points behind, to try to assemble a team. This is what we end up trying to do all the time and failing, leading to institutionalization. By having that team when very little is being asked and developing it and sustaining it, then we can avoid the kind of social isolation or dependency on a single individual that leads to problems. And it leads to care crises. So we need to have a plan for the unexpected. What happens if the spouse gets sick? What happens if the spouse dies? There needs to be a plan, an explicit plan in place for those who would fill in at that point. The rest of the team need to be identified and come to play the game. This makes a big difference for sleep hygiene as well, getting people to have adequate supervision. Many times our system fails when there's a mismatch between the patient's needs and what the system or the family is able to provide. So I want to go on and talk about how we manage some difficult behaviors. Behavior is affected, obviously, in dementing diseases in different ways. For frontotemporal dementia, behavior is often the first and most prominent symptom. In fact, many people with frontotemporal dementia end up being cared for in psychiatric units inappropriately because doctors don't really know what's going on. But here's a list. You know them. You've heard about them. You've seen them. Different problems. Each of them require a different approach. Now, how do we manage behavior? Well, I've told you that we need to have patients and family members have to have a team that's been assembled to avoid problems, but when they arise, we need to be able to call upon them and to evaluate whether they have been able to carry out some of those recommendations. As we heard this morning, it's very difficult because of reluctance of families to make changes or patients to make changes to have everything in place. But medications are a last resort, if at all. All difficult behaviors are transient. And so if we can get people over the hump, if we can identify problems early, begin slowly, increase gradually with medications, we're going to do much better than treating patients who are out of control in the emergency room. So we need to be proactive about this. We need to look for warning signs. I tell families, if a patient is in an assisted living facility or a nursing home, what is the staff telling you? Are they completely comfortable or are they a little edgy? What happens frequently if you don't have these discussions early is that the staff will look forward and say, you know, there's going to be fewer people here on the weekend, and already I'm not sure if I can handle this, so it's Friday afternoon, maybe they better go to the emergency room because we're not prepared. Well, we can prevent that if we are given a chance. So we need to anticipate needs and look for warning signs. It's important to recognize that similar behaviors tend to recur, even though they can go away, and they often fluctuate. There are periods of time that patients don't need medications, and if we can get over the hump, we'll do well. We need to decide on a specific target symptom. Here's something that happens frequently. Patient is agitated. I start a medication. The patient's family calls up and says he's worse. Now, the first impulse is to say, okay, well, it looks like that medication didn't work. But the answer, if you talk to the family, is they're worse because now they're sleeping all the time. Wait a minute. Our target there was agitation. So we've actually been successful. All I have to do now is back off on the dose. And I've got the problem solved. But if I just stop the medication, guess what? The patient's going to get more awake, but they're also going to get more agitated again. It's just going to be put off to about a month later when that medication gets changed. So we need to manage the manager, consider the patient's perspective, try to see if it's really a problem with the management of the patient or whether it's the disease itself that's causing this problem. Are there medical problems that are contributing? The patient have a urinary tract infection, for example. Now, my friend Chris Clark at the University of Pennsylvania came up with these brief pictures here, the little cartoon, but I found that very helpful to me. How do we know that everything is okay right now? You're all sitting there calmly. Many of you are awake. So you're not very anxious because everything around here is predictable. I'm giving a talk, you're listening. People are coming in, removing the plates, and that's fine. We know that from our previous experience. We know from our previous experience what we should be expecting in the next 5 to 10 minutes. It's not completely in disarray or chaos. And so, really, our cognitive space, so-called, we're sitting right here today, depends upon the past and permits us to predict what the future is. Okay? Now, as dementia progresses, this cognitive space decreases. We have less experience. We're not so sure what happened to get me here. Suddenly now I'm a little more anxious because I'm not quite sure if this is a hostile crowd or a good crowd. And if there are a bunch of people in white coats, I'm not quite sure what they're planning to do to me. So this progressive decrease in cognitive space affects our current behavior because it affects our future expectations. And eventually, in severe dementia, we have to live in the right now. So I have to be deciding right now, is this a threatening situation or a comforting situation? Just on what I'm seeing right now. And that means there's much less buffering. A doctor rushes in with a white coat, wow. Or A patient goes out and there's a bunch of traffic going this way and that, chaos. So thinking about behaviors in the context of the patient's experience can be very helpful and informative. Now, how should caregivers respond to abnormal behaviors? This is really important for you to know, because you're going to have to explain this to family members who don't understand, don't have the experience with this. Logical arguments and factual discussions are counterproductive. No, this isn't your son. It's your grandson. Don't you remember? Doesn't work. You need to be reassuring. I had a really interesting case I'll have to tell you about. This was a family. Unfortunately, they did not follow through with our proactive plan. They elected not to see the health educator. They elected not to meet with the social worker. And they elected not to return to my clinic. Maybe that was a big problem. I don't know. But anyway, I heard about this patient about a year and a half later. Family hadn't really made any adjustments that I would have recommended. But they decided to have a birthday party for the patient. And it's her 75th birthday. And so let's have all the family in. And let's have the neighbors over. And we have a bunch of kids running around. And the patient became increasingly agitated and upset. And so what she did is she escaped to the quiet part of the house, the bathroom. And she was in the bathroom. And, of course, all the family was going on. Somebody noticed, where's Mom? And they started to look around, and they noticed there was somebody in the bathroom. And so, Mom, are you in there? Yes. Are you okay? Yes. So they went back, had the ice cream, and Mom was still in the bathroom. Are you okay, Mom? Mom, are you okay? And then we heard click. Lock the door. Uh-oh, now what do we do? So the son decided he would get the ladder because there was a window into the bathroom. And so he could go in and see what Mom was doing and make sure she was okay. And so he did that, and you can imagine what happened. Something was thrown at the glass, and the glass broke, and the son went down, and so went down the ladder, and so she was beginning to get upset. She was beginning to scream, "Somebody's trying to break into the house! Somebody's trying to break in the house! Help! Help! Help!" But the door was still locked. So they didn't know what to do. They hadn't heard any of our discussions. So they called 911 because this is a problem, because she was there and they couldn't get her out. So the firemen came and took out the axe and took down the door of the bathroom. And sure enough, they got Mom out. But by this time, Mom was really upset. She was hitting people, throwing people around, screaming, everything. So that led to an emergency room visit. As you can imagine, she's admitted. And that's when I got the call about 3 weeks later into that psychiatric admission when she was completely sedated. And now what do we do? Because we can't discharge her home because she's non-ambulatory, completely sedated. So I hope you don't mind my telling this little story. I have plenty of them from my experiences with this, but it illustrates what happens when families do exactly the wrong thing rather than being calm and reassuring. I don't know if any of you had this experience, but my son actually did this himself once, but he came out after a little while and we didn't pay any attention to him, which is what this family should have done, as well as probably cutting down on the chaos. So we need to tell families they should be quiet and be able to be calming and reassuring. Tone of voice makes a difference. Body language makes a difference. And we need to decide not just what we don't want the person to do, like hitting, yelling, but what we want them to do so we can focus on that task. We need to think about, is it the caregiver who's depressed that's causing this issue? Are we giving the patient adequate physical activity, adequate social activity? If not, then this may not be the adequate support that's needed. So caregivers need to know that they should avoid challenging the patient and instead divert attention. They need to maintain consistent, active, daily routines that are predictable for the patient, that they can call upon even in their subconscious, that, well, we always go out for lunch, or we always go for a walk in the morning, or we always go to the dance, go out to dance at night. And instead of avoiding constant reminders, I don't know if you've seen this, but it happens in my clinic all the time. We're going to see Dr. Foster on Monday. Get ready. We're going to see Dr. Foster on Monday. Monday comes, he doesn't remember it, but he does remember the, now it becomes an acute thing, and the family tries to get the patient dressed in time for that 8 a.m. appointment, and it's quite a challenge. So let's talk a little bit about medication use. Medications have their side effects. They are appropriate to use. I advocate using medications when they're needed. But you have to realize that there's always a price to be paid for any medication, and that an educated caregiver is an important ally in use of any medication. Begin low, go slow, discontinue when possible, and you can not just discontinue medications, but gradually taper medications. Look at the long range. How about anxiolytics? I avoid these as much as possible, particularly benzodiazepines. They are an experimental form of Alzheimer's disease in laboratory animals. So I think that they can be used preemptively when you know there's a situation like the birthday party that we're going to have, that they can be used preemptively, but they're very ineffective if they're used daily and patients develop a tolerance to them. I like minor sedatives when patients are beginning to be a little edgy, a little irritable. Family members are afraid to say anything or to do things because the patient might go off the deep end. This is when minor sedatives like trazodone, I think, can be very helpful. This can be started low and gradually increase as needed. If the minor sedatives, anxiolytics don't work, then we may need to go to bigger guns. Antidepressants are very helpful if the patient is actually depressed. You have to ask questions to see if their mood is changed. And I have some examples here to give you an idea about that. Now, I try to avoid antipsychotics. My two preferences are listed here. And again, beginning low, going slow. When you have the opportunity to do this preemptively, proactively, with the first changes, it works much better. And there are side effects of these medications, but the purest play is haloperidol because it's primarily a dopamine blocker. You need to know that many of the antipsychotics are also anticholinergics. It doesn't make sense to use an anticholinergic with a cholinesterase inhibitor by and large. So look at the profile of the antipsychotics. And this is our website. Happy to have you go there and take a look. We also have a number of research studies. I'm sorry I can't tell you about all of them, but we have many promising therapies that get at the basics of Alzheimer's disease, the beta amyloid, things like immunotherapies, which we're using quite routinely now, that are available in research studies, immunization, active and passive immunization efforts, and you'll soon be hearing we've gotten our IRB to approve the first genetic therapy for Alzheimer's disease in the state of Utah. So many things. Patients who are appropriate for research primarily have probable rather than possible Alzheimer's disease, meaning uncomplicated disease, and symptoms are mild. So I wanted to leave I don't know if I have a little time to answer questions. I hope you've found this helpful. And the best challenge is really the real world challenge. Yes, in the back.
Sir, what do you attribute our preeminent status?
Why is Utah number one in the country? And the reason is because our population continues to increase. We have the third greatest longevity of any state in the United States. Number one's Vermont, number two, North Dakota, and number 3 is the state of Utah. So that's good. Our medical care, our lifestyle is superior to most of the country, so that's an important factor. We continue to have in-migration in this state, and people tend to retire here. It turns out that the highest percentage of people with dementia are actually in states like Arizona and Florida, but they aren't going to be changing so rapidly because they're dependent upon inflow primarily. In Utah, our population pyramid is like this. You may know in most of the country it's like this, but we have a high proportion of younger people, and so as they're getting older, that percentage is increasing. So all those factors are contributing. Yes?
Severe osteoarthritis or whatever condition may be going on that's causing them grief and agony.
So the question is, how do we treat pain in patients who have Alzheimer's disease? And this is an important question because comorbidities are common. My first approach is not to change my approach in that I want to encourage them to keep physically active. I want to have them focus on things that they need to be doing rather than accepting disability. I try to use over-the-counter pain medications first. I think that long-term narcotics are a bad idea, but there has to be some balance. Just as we heard this morning, negotiation may be necessary. We just need to be honest with ourselves and with the patient and with the family what the possible price is. I'm highly sympathetic to physical therapy, physical approaches. I realize that insurance does not always pay for patients who have chronic problems. One of the things that we do in our center is that we have made a commitment that our medical recommendations will be what's medically appropriate, not necessarily what insurance reimburses. This is an important issue that families actually have to address early because I was telling you many of the things that are needed, adult daycare, assisted living, eventually nursing homes, those are not paid by insurance. So we don't want to be, it is no long-term saving to not pay for things like health education, social work, medical visits, because that's just going to lead to more expenses and a more intensive therapy later. So it's a long-winded answer. I want to focus on things. In patients, some patients with dementia will develop compulsions and obsessions. I've had patients who repeatedly go to the emergency room complaining of pain, chest pain, and the family will react to that in the usual way, not realizing that it's related to the anxiety that's going on and the chaos around them. So this is partly a matter of talking to families, helping them understand what the situation is. Yes? Is what covered by?
Is much of this covered by what you presented, covered by a book?
Oh, covered by a book.
Yeah.
Well, what we're trying to do at our center is be cutting edge. So my job, and Troy Anderson, my social worker, Kathy Moran, my educator, we have published a couple of papers about this, and we have several more papers to come. This is not, I don't know, Moni, have you heard this? I mean, it's not, there are pieces of this in different places. The best thing for caregivers is the 36-hour day, which is a long-standing text that covers much of this. But from the physician's point of view, I was just telling Moni, we submitted a proposal to the NIH to examine the effectiveness of proactive care, and it was declined because it was too innovative. So that is an indication that it's probably not widely published. Yes?
My question is being a primary care physician, oftentimes we don't do the full testing before we decide to begin treatment. Is there any detriment to starting treatment too early? I mean, like starting on a medication like, let's say, Aricept or something of that nature?
Well, I think the main deficit, I have a lot of things to say about that, but The main problem is that studies have shown that cholinesterase inhibitors are given very inconsistently. So what typically will happen is that patient will come in, they'll have a memory problem. You're not quite sure what it is. Let's just try symptomatic treatment. Let's start Aricept and see if it helps. You may know that these drugs are not very beneficial. They have a marginal benefit. But what will happen is that in a month, so that gets you by that day, but then you get a call a week, 2 weeks, a month later, they come back to see you in clinic, things are worse. Well, maybe that drug doesn't work. Or maybe it's because the diagnosis is wrong, or you haven't made a diagnosis, so you don't know how to handle that. But often what happens from studies is the average duration of treatment with the use of any of the cholinesterase inhibitors is 6 weeks. That's the average duration. And the average patient with Alzheimer's disease, even though these cholinesterase inhibitors are essentially equivalent, receives 2 different cholinesterase inhibitors, and many people get through all 3 at some point in their illness because the physician isn't quite sure. If this is symptomatic treatment, how do we decide? Were they going to get worse anyway, or does this mean it didn't work? Or it's really complicated. And so I think that it only creates problems without knowing what the cause of the illness is. So I think early referral. You may know that we're trying to discourage late referrals. We focus on early interventions to prevent problems. We do not do crisis management. So that's one thing. Another thing I wanted to mention, since you gave me the opportunity, which I may have mentioned before, is we have research studies, including availability of PET imaging. We have some highly advanced image analysis methods that aren't available otherwise that may be very helpful in early recognition and diagnosis. Yes?
Yes, with a progressive disease like Alzheimer's, how do you make a decision of when to discontinue medication or if it's necessary? I work in the VA system, and as you know, we have a geriatric department, and they're very closely linked to your department. But these patients I have, they've been on Aricept and Namenda for years, and maybe they're getting a little worse. I send them down there. They do this big giant workup, and their bright idea at the end of that workup is to, hey, let's see how you do off your medicine.
Well,
so how do you make that?
You're right that we have many associations with the VA, but we do not have a program at the VA, and I'm hoping that we will soon, and I hope that we'll be able to maybe give you better advice about that. But so let me give you some ideas. First, if patients are on multiple medications, simplify their medications. So I have a patient who is beginning to get, actually she's quite worse, she's at home. Her mini-mental state is 3, and she came back to me, she's taking 12 different medications. This makes no sense at all. So prioritizing medications and limiting those to absolutely the most important ones is important. That's one of the reasons I'd stop. Number 2, cholinesterase inhibitors can affect urination. So when patients are having difficulty with incontinence, I tend to stop cholinesterase inhibitors. They're procholinergic. We give anticholinergics to try to control that. If there is, I often will, with the same idea in mind with simplification, try to decide what am I trying to do. If I'm focusing primarily on behavior and drug interactions may be an important thing, then that may be a time to stop drugs directed solely at symptoms of Alzheimer's disease and manage behavior. And then finally, the question is, what are the potential benefits? So if a patient is completely dependent on others for their care, they don't have any activities of daily living, if the drug is effective, it's not going to be marginally beneficial. So these are all appropriate clinical judgments. I think that The VA, as you may know, has a system that doesn't make any sense to me about discontinuing medications and rationale. Likewise, you may know that in England, talking about healthcare reform, the National Health Service in England has decided that drugs for Alzheimer's disease shouldn't be used early in the disease, but only late in the disease, hoping that it would delay the cost of nursing home care. That doesn't make any medical sense to me at all, but some health economists, did some calculations and decided. So there still is a lot of judgment because of marginal benefits of these medications and significant costs. We have to weigh all of these things. Nobody with agitated patients, problem patients? We're happy to. I think our clinic phone number there is on our website, and we're very happy to talk to you about problems because we'd like to avoid getting called in at the last minute or after things are late, and we'd be happy to talk to you about any patient care issues. Thank you for your attention.